All right, so welcome to my next video. This is going to be on esophageal varices, ABSITE, high yield stuff, and it's all based off of the core curriculum. Esophageal varices are one of the most dangerous complications of portal hypertension, and on the ABSITE, the questions are almost always about management. Who gets beta blockers? Who gets banding? When do you place a Blakemore tube? When do you do the TIPS procedure? In this video, we're going to make the entire variceal bleeding algorithm very easy. By the end of the video, you should be able to explain why varices form, recognize acute variceal bleeding, manage bleeding versus non-bleeding varices, and understand TIPS, balloon tamponade, secondary prevention, and hopefully should help you ace the ABSITE when it comes to this topic. What are esophageal varices? Varices are abnormally dilated veins that develop because of portal hypertension. The core concept follows as blood can't flow normally through the cirrhotic liver. That leads to portal pressure to rise, which then leads to blood getting redirected through the collateral veins, and these veins dilate and become more fragile. So where do varices mostly form? They form at sites where portal and systemic circulation communicate. So high-yield locations are the distal esophagus and proximal stomach, rectum, and presents as hemorrhoids, periumbilical veins that we famously know of, caput medusa, as we learn in med school. Esophageal varices are the most clinically important because bleeding can be catastrophic. Acute variceal bleeding. This is a true emergency. These patients can rapidly progress to hemorrhagic shock. They can develop respiratory compromise and even die. The classic presentation, usually with hematemesis, melena, and a cirrhotic patient with progression to hypotension and tachycardia. The initial management for these patients always start, if you see these patients, through the ABCs: airway protection, getting large bore IV access, and resuscitate these patients. They often need ICU level care. The transfusion target, or the AASLD, recommends the hemoglobin goal for these patients to be between 7 and 9. Overly transfusing these patients can actually worsen portal pressure. What are the medical therapies for this topic? First is Octreotide. It's the first-line medication, and it's typically an infusion. The mechanism is it causes splanchnic vasoconstriction, decreases portal flow, reduces bleeding, and is usually continued for 2 to 5 days. Antibiotics is very high yield. All patients with variceal bleeding get ceftriaxone prophylaxis for 5 to 7 days. Why? Because antibiotics reduce SBP, sepsis, and mortality. What is the definitive management for these patients? First line is endoscopy, with the definitive treatment being EGD with variceal band ligation. This is the gold standard for active bleeding. Banding mechanically obliterates the varix. Balloon tamponade. If this patient is bleeding and it's uncontrolled and they're hemorrhaging out, then you need to put either a Sengstaken-Blakemore tube or a Minnesota tube. And remember, this is temporizing and not a definitive management for these patients. It's important to remember that the gastric balloon must be in the stomach before inflation. Otherwise, there is a risk to esophageal rupture. How it works, gastric balloon is typically inflated. The tube is placed on traction, meaning you're pulling it back, and then this compresses the varices at the GE junction. If it's still bleeding, then you can further inflate the esophageal balloon as well. So when do you do the TIPS, or the transjugular intrahepatic portosystemic shunt? This is a shunt that creates a low distance or a low resistance channel through the liver to reduce portal pressure. Indications are refractory bleeding and recurrent bleeding despite endoscopic or medical therapy. TIPS decreases portal pressure very effectively, but it can also worsen hepatic encephalopathy. So it's important to remember these patients can get very altered. So when it comes to non-bleeding varices, let's talk about prevention. First line is non-selective beta blockers. Examples are corvedolol and propranolol. These decrease portal flow, cause splanchnic vasoconstriction, and decrease cardiac output. You want to titrate these medications to a resting heart rate of 55 to 60. The alternative to this is band ligation, where you can place an endoscopic band, and it's been shown to is equally effective for primary prevention. But beta blockers generally have fewer complications, so this is preferred. Secondary prevention. After a bleeding episode, remember patients should get both beta blockers and repeat endoscopic banding. These bandings should be repeated every 2 to 8 weeks until varices are completely obliterated. After recovery, so the post-bleed follow-up, you want to resume beta blockers, monitor for rebleeding, and then do your surveillance EGDs. Remember that the most definitive treatment for these patients overall is going to be liver transplantation. That's pretty much all the big things. So we'll review using our high yield rapid fire. So remember, cirrhosis causes portal hypertension, and with the collateral blood flow causes varices. If you have an active bleeding patient that's cirrhotic and high risk of variceal bleeding, then they need the ICU. You need to do your ABCs, get a peripheral access or some type of vascular access for blood transfusions. These patients should be started on Octreotide and antibiotics immediately. EGD banding is the first line definitive therapy. If they're having hemorrhagic shock, you can place a Blakemore tube as a bridge or temporizing measure. And then if they're having refractory bleeding, again, you can use TIPS. And then the big thing for prevention is going to be beta blockers that we've reviewed multiple times. That's the entire variceal bleeding management pathway. You should be able to answer any question that comes to you as it relates to varices. Remember that I'm doing an entire series on the ABSITE directly through the score using this type of format. So leave a like, comment, and tell me any ways I could improve and make this more watchable and enjoyable. Thank you for watching.